least crazy case. That's really
Oh,
okay.
you can go last. You want to go last?
No, it's okay.
It's by height order, Lucy. It's by height.
Really interesting.
Yeah.
With me on stilts.
Oh, and Sunil and whoever for Cobra after that, if you guys can stay a few minutes after and talk about it.
Yeah.
Yes.
Hey, Kelly. Bringing the Bausch rep in the house.
Of
What are you watching in
course.
the what is she what is she in the background? That's all I want
Oh, American Ninja Warrior.
to
Summertime.
know. That's awesome.
Here's up. I have a large Bausch & Lomb jacket on because I'm freezing in my basement.
Mm.
I see some incoming Cole Retina fellows trying to nice up to their attendings joining us today. Very
Yeah,
smart.
it's a good way to start always.
It's very smart. Yeah.
I mean, especially for Kat. Kat's like hard on them. She wants to.
Yeah, just keep praising Dr. Talcott. Excellent comments.
Keeping notes, like little tally marks.
Thumbs up.
Yeah, I see it. You see like Kat doing that. She's like, okay, who's here?
I already asked one of them to write a chapter and they said yes. So
Gillers knows one of our senior fellows, and she's graduating from us and finally leaving Stanford after all these years, and will be joining the faculty at the University of Pennsylvania as a clinician scientist. And she starts it off with some great animation of a intravitreal injection gone very wrong, it looks like.
All right, unmuting myself. Yeah, this is AI generated, obviously. It's not up to par with some of Jared's best work, but this is like my best shot. Okay, great. So I'll be presenting a case of a myopic macular hole retinal detachment that I did with Dr. Chase Ludwig a few months ago. Not like glamorously crazy, but I think there's a lot of points for discussion here. So I think this is a case that was kind of very intimidating from the start, but I think there were a lot of learning points along the way. So we'll start with a 74-year-old man with vision loss for the past year, at least, in his right eye. His vision in the right eye was hand motion, vision in the left eye was 20/25, and the best corrected visual acuity that was ever recorded in the right eye was about 2100 in the about more than a year ago, so indicating there's probably some amblyopia there. It's phakic with 1+ nuclear fluorosis in both eyes. This is an optos of that right eye. I'd like to draw your attention to this retinal detachment of the posterior pole that I've outlined here with the subretinal fluid standing to inferior to the macula, and drawing your attention here to a macular hole in this eye, which is we were sure that we saw on the optos and on exam, which is important here because actually we took a bunch of OCTs through this macular hole, and this was, I guess, one of the crazy things here is that this hole never showed up on OCT, even on the radial scans, but we were sure that it was there. And here's the B scan, which was helpful, showing us that there's a posterior staphyloma with a detachment posteriorly involving the macula. And drawing your attention to the biometry here with axial lengths of 28 in the right eye, and I said only 25 in the left eye. And the fellow eye, the left eye, was fairly normal. It was not staphylomatous at all, just a mild ERM in this eye. So,
Kat Talcott, I have a question.
Yeah.
Do you always get axial lengths on every myopic patient? That's for Kat.
Oh,
that's not. Yeah, you did.
Okay.
That's great. I was just asking. I'm asking Kat if she does, and when won't you do that, or when do you always do that?
definitely take advantage of every time, Lucy, where somebody else gets asked a question that you get to take a break from being on the hot seat, especially at COBRA send-off. I don't get axial lengths on any of these people. I don't find that it really sort of changes my management at all. Like, I already know that the axial length is going to be long. I can sort of, you can tell by the imaging and it's going to be long. I mean, the things that you worry about if you're going to do surgery on these patients are your forceps going to be sort of long enough? Do you need to make any sort of extra plans? But I don't think getting the axial length changes my sort of thought there. And you didn't sort of quite ask this, but these cases are really complicated. And so I just try and get a really good history of, what was the vision before this happened? How are they functioning? Because I try and find any reason not to do these cases if I can.
That's a good answer. Asan, do you get axial lengths, and does it change what you do?
I don't get it. I don't even know if we have the capability to measure it here. I probably wouldn't. What's I think interesting to me is I get a lot of these high myo patients asking for it lately. And one thing I've learned is it's a practice our optometric colleagues have started to really integrate, especially when you start talking about myopia management. And and my understanding is insurance, generally speaking, doesn't cover for it. So I don't know if this is something that they're paying cash pay per visit. I agree with Kat and all the other points. It's not going to change anything that we're going to do. We already know with these staphylomas eyes, it's going to be a tougher peel. There's some tricks about, taking the trocar out, using some of the longer shaft forceps in these type of cases. I don't know what measuring the axial length does for you though, otherwise.
Take it away. Go ahead, Lucy.
All right, great. Moving on. Okay, so this is, in summary, this is a phakic Markov RD with a macular hole in an eye with pathologic myopia with posterior staphyloma. So for our surgical planning, we decided to do a 23-gauge vitrectomy, and drawing your attention to some of these lanes here. And this really nice article written by Dr. Ledwin, Dr. Mashfeghi, and retinal physician, where I think Chase actually called the reps at all these places and actually got the lengths of these surgical forceps. So I think we've always heard that, the 27-gauge forceps are longer. So we've used this, I think, for a lot of our myos, but to see actually the numbers here are very helpful. So we use the 23-gauge. The plan was to do a fovea sparing IOM peel with an inverted flap using a temporal hinge. Planning on draining a subretinal fluid using a posterior retinotomy, which I know is often a subject of contention at COBRA, and then using gas with C3F8. And I'm curious if others in the audience would have considered alternatives here, such as maybe using a broad peel or using amniotic membrane to start with. I've read about this PFO marble to assist with peeling out mobile retina, which I haven't used yet. And potentially, draining through the macular hole, which we decided not to do here. Also, macular buckling was considered here, but was not used.
There's another forceps. Neil, do you use the very awesome Bausch forceps for long eyes?
These are all what you have in your cupboard, what you stock. And so I think every company kind of makes their own. I've used the Bausch ones. They're lovely. And I think it's all about stability of the handle and which one you like the best and what kind of tip you like. But yeah, I think, it's whoever makes the one that you tend to like. So the myopic, the Bausch myopic work nicely. There's a Vortex myopic. There's a bunch of the different ones. I would just ask your favorite rep, whoever that may be, to grab one. And we stock a bunch of these just to have them because we're large enough. But sometimes you're not going to stock these because it's a one-off thing. So this is one scenario where maybe knowing that the eye is a little bit long is helpful because you can ask for the forcep to have it ready. If you didn't know it was very long, you may not have it, and then I don't say you're stuck, but it's a little more challenging.
So this always comes up around here because there in the Bay Area, we had a retina practitioner that would put macular buckles on. And so there's a lot of people who walk around with macular buckles. Carolyn Pan, what's your favorite element for a macular buckle? Is this an indication in this case? And thinking of these other alternatives, do you want to comment on how you might approach this?
Yeah, my favorite element for macular buckles is no element. I do not do macular buckles. I think the last time I tried one, I was a fellow, and I regretted it the moment I started trying. I think around in the Bay Area, that particular surgeon is now retired, but he did like a macular sling, which is interesting. I think like Kat, I really try not to do these cases if I can help it. Because even if I can close it and reattach it temporarily in 6 months, a year, you know, 2 years, I'm not fixing the sapphiloma. I'm not fixing that eye that's getting longer and longer. And it's just, it feels like it's a temporary fix. And the visual potential long-term is not great. But I think that their plan is a good, like, first approach.
Okay, great. So here's the video. So this was done in Ingenuity, which is a way to guarantee that my peel videos are in focus.
Sumit, could I just ask you about cannula placement? Just can you pause a second?
Oh yeah, sure.
Yeah,
Lucy?
actually go back. Yeah.
Yeah, can we go back? I know you love cannula placement. I just had to ask you. Like, so in general cannula placement question, but also in this type of potentially long eye, or let's say you add a millimeter to the axial length, what are you doing differently?
I mean, the only thing
What
I'm
aren't you
considering is a couple things. One, if I'm really worried, or if I don't have a great myopic forcep available readily, and I'm worried about the length, my supratemporal, or my, actually, depending on the eye, my right hand cannula, I'm the one that I'm going to be peeling with, I will put in straight. I won't bevel it in case I need to open that up and go in a little deeper to be able to get the shaft of the forcep itself. But otherwise, you know, always cognizant of where I'm placing them, in terms of, if I know I have a retinal detachment with a break at a specific spot, I don't want the break right under one of the cannulas. So I may adjust the position slightly and rotate slightly, but those are kind of the big tips that I usually have for these.
And a tip that I learned from the peds folks is that you can transilluminate. Trying to figure out on the peds side not to go too far posterior, but you can transilluminate and then see where you can go if you needed to go further back. But I think what you're saying, it makes a lot of sense. Not beveling that one side might be a good trick.
Okay, great. Yeah, I think here we made sure to put the trocars like closer to 3 and 9 to, you know, not to kind of try to make this as ergonomic as possible and not to overload ourselves. Spares you guys from most of the vitrectomy. So here, after the first ICG stain, you can see that there is a flap kind of superiorly, which was the first thing we tried to go for. But it was still really hard to see, so we end up restaining, and here using a soft tip to kind of gently stroke to loosen up that superior flap, which is what we started with. And at this point, we actually considered, you know, should we do a superior hinge if this whole thing, you know, comes off in a nice sheet. As you will see, that's not how it went. So the goal here was to, you know, loosen the this sheet as much as possible with a flex loop, and kind of do this in a broad stroke. You can see here that it's pretty adherent. And also what I was noticing already here is that the reach, especially nasally, felt very awkward, just, you know, how long the eye was. I think we're on 2x here. You know, trying to do this slowly, but trying to peel off like a sheet that was as whole as possible. But it was, you can see that it's kind of ripping off in small streaks.
If I can just make a comment. Sorry, Asan, go ahead.
Go ahead, Kat.
Oh no, just in general, when you're using the flex loop at that angle, kind of superior going down, that's a really awkward sort of angle to be at. You know, obviously we kind of go with what we see already, so you kind of have to go with that. The other thing is, like, when I'm peeling on detached retina, it's always easier to peel where something is, you know, where there's like an anchoring point to where it's not. So sort of, if you can, you know, obviously you want to take advantage of the flap, but starting sort of nasally and kind of going over makes it a little bit easier too. Looks like you're having more success as you get a little closer to the nerve here.
Yeah, definitely. Yeah, I think the things that were challenges, the things that were challenging here included just the, you know, the lack of counter traction, which we're used to while peeling.
So I find each septa go much slower in detached eyes and just kind of keep it under constant tension. And if you just do that, it'll eventually, as you're doing here, nicely start to come up for you.
Isan, is the goal here to flap in your case, or are you just looking to peel the entire ILM off?
It's both. I mean, if a flap is residual, that's great. I'm not gonna cry if it's not. You know, I want them. I want the fellow to focus on no iatrogenic injury when they're pulling across. You know, focus on not hurting first, and if we'll see what's left. The goal is to try to have a flap. I think that's great. If not, it's not the end of the world.
Lucy, this is you're peeling on top of detached retina. Tell us what you're feeling, experiencing. How are you altering your
Yeah,
motions?
exactly. I think someone already mentioned just going more slowly, low and slow, as the Chase would always say, so we did a lot during this case. And then we definitely felt like, the temporal reach here was, felt a lot, smoother than trying to reach nasally. But here we were trying to grab like through the last little bit of IOM nasally. And what was nice about the ingenuity here, as you just saw, was that I think with teaching, it's a lot nicer because you can kind of point the cursor to where we wanted to go.
Luce, that's what I was actually going to ask you earlier. With having done it this way, do you think in the future you favor then that 3 and 9 position? Because that's where a lot of the challenge comes from. Getting something nasally is the more horizontal you are. I'm just curious what your feeling is after having done it that way.
Yeah, I do feel like in retrospect, I mean, it felt like a little more awkward reaching nasally. So maybe in the future we can go maybe a little more superior. But I think it still worked out okay for this case.
Yeah, you did beautiful, Peel. Great job.
All right. So, oh, I forgot to point out that one of the crazy things that happened in this case, I don't know if that was highlighted, is that so there was a point where we felt like the temporal flap that we made was like not actually covering the hole, but then during the air fluid exchange, it actually like moved to cover the hole, which was really cool. that kind of worked out. All right, great. So postnatal day 1 looked good with full gas fill. It looked like the flap was over the hole. Post-op week 1, post-op week 3, he came in with a symptomatic new floater, which I was really worried that was the flap that was like floating, but it turned out not to be. And post-op month 1, the gas cleared the center. We can start to see that the hole is closed. Post-op month 3, still looking good. And yeah, I think the final vision from the previous visit was counting fingers, there's 4 feet. So definitely some improvement from hand motion. So
A retina win. That's like retina 2020.
yeah.
Look at that beautiful OCT. Reoriented the OCT.
Yeah.
That was a great case.
Thanks.
Hey, Luce, I'm sorry if I missed it. Did you use steroid too here or no?
Yes, in the beginning we did.
Okay. Did you end up seeing much vitreous? You didn't show us the vitrectomy. Did you deal with a lot of like vitreoschisis and stuff in the periphery or no?
Not as much in this case. Yeah, we didn't spend a ton of time doing the peripherectomy here.
I think out here west, especially on the West Coast, we see so many of these super high myope eyes in the patient population. It's just always one of the things we harp on with you guys is always use steroid in these cases. Always residual sheets of hyaloid and all this stuff if you want to get a complete good vitrectomy. Great job.
More Kenalog better? Is that what I heard? Us? That's exciting.
Kenalog or Triessence? I don't know. What are you guys doing over there now?
We just got our Triessence back, so I think everyone's trying to get used to using it again. But I think many of us are using Kenalog or Triamcinolone.
What about you, Hassan? What are you doing?
We formally, I think, switched back. It was always a policy in the hospital system here that Kenalog was black box until, we were forced to use it, and I guess they're happy to pay for it. I don't. It doesn't bother me.
Yeah, it's amazing. You can't use it. Only it's not around. Go ahead and use it whatever you want.
Yeah, exactly.
Yeah, I know.
Nice job, Lucy. Great job. Great work. For next up, Eric Chung. Eric is graduating, has a job. Congratulations, joining the Retina Partners in Southern California. Eric's gonna. I guess we're doing all AI generated title slides. Take it away, Eric.
Alrighty, thank you. Just inspired by Jared, as you know, and can't really live up to it, but here we go.
Who are the 4 people with like these ghostly stares?
Don't look too closely at the faces. You'll be a little confused by. I think AI was.
Why does one of them not have a mask on?
All right. Thanks for letting me present here at our last COBRA. I promise not to cry too much. We have a 27-year-old female. She's got diabetes type 1. Sorry, I left out the 1. presenting for initial evaluation in Dr. Sharma's clinic. She reports worsening of her vision in the right eye recently, while the left eye for an unknown amount of time has just been chronically poor. Here are some B scans because she's got some vitreous hemorrhage of the right eye precluding any view. Vision's 2250 in that eye. She's got vitreous hemorrhage and some associated traction, but it's not too bad. Left eye, as you can see, is much worse with basically a tabletop TRD configuration. Vision is hand motion at this time. So I'm going to skip over the right eye. My co-fellow Rachel Downs did an amazing job putting the right eye back together. As you can see, vision was 2200, and then I swooped in at the last minute for the oil removal case. During that time, we also gave the patient an Avastin for the left eye because we are planning to now get involved there. So just to kind of show you what the left eye is looking like, this is her pre-op. She's hand motion with this big plaque that looks nasty. B scan again is shown on your right. So here we're planning a TRD repair. Again, we did inject Avastin into this eye actually while doing the silicone oil removal of the right eye. Plan is to do a combined cataract surgery as well, and gas versus oil. You know, she's got some use of her right eye now, so oil isn't absolutely necessary, so we can now think about gas if possible. Moving on to our case here. So magically, our cataract is done. And you can kind of get a view of what's going on here.
So Eric, can you pause for a second? Did
Yep.
you think that was when you first got in after the cataract was done? Was that better or worse than what you were expecting?
To be honest, I
That
think it was a little worse. Not because the B scan didn't look bad, but I think we were kind of hoping, hey, maybe we'll get in the eye and like a lot of that stuff that was elevated, maybe it's more the hyaloid, thickened hyaloid, and maybe it's actually better than we hope. But unfortunately, no, we got in the eye and we're kind of presented with this big old thing that did not make
And
us.
talk me through how this has evolved for you over your 2 years. What have you learned when you see a case like this? I can imagine when you first started, super intimidating, still intimidating now, but what like kind of grounds you? What do you know that what is your mental plan when you walked into this eye?
Yeah, absolutely. I think kind of going back to the fundamentals and, you know, with diabetic cases, anytime there's posterior traction that I'm looking forward to addressing at some point, then I'll kind of start out by trying to release AP traction, seeing if there's a pocket I can get to in the mid-periphery or periphery, where I can access the subhyaloidal space, kind of take that around. If I can get release 360, then I can feel comfortable that now I can address some of this posterior stuff and kind of go piece by piece. I found that, you know, trying to take what the eye gives you and not getting too frustrated if something's not working, you know, trying to avoid feeling rushed or feeling impatient and maybe moving on to a different area to stay patient has been kind of one of the main things that have helped me out in these
Staying
longer.
patient and Dr. Sharma's OR is always a good thing. Don't keep going, man.
All right. So yeah, as I mentioned, we're taking stock of what we have, but you know, first things first, we're going to try to see if we can get some AP traction release going here. And thankfully we did find a little entry point, and I'm kind of unzipping that and continuing that along here. Obviously, in these cases, you always want to be cognizant of where the retina is. And, you know, our retina is elevated, you know, at some points, you know, over here, you can see, I don't know if you can see my mouse, but just being aware of your depth and making sure you're staying safe. Then we're going to our green lens, getting more of a posterior view, but clearing out as much vitreous as we can so that some of these planes are more easily identifiable. And then now going after the plaque. So
So
when it
what are you
comes
thinking now? Yeah, so pause that
right.
for a second. So so here we're here, you've released the AP traction. And
Mhm.
then kind of and we talked about this in the case too, kind of what are the different ways that you can address this at this point?
Absolutely. So You could do an outside in, you could do inside out, you could do a combination of both. I actually prefer to do kind of an inside out approach if there's any sort of access by the nerve, because that's kind of my one landmark that I know I can always fall back on. However, in this scenario, obviously with such a bad sort of tabletop configuration, we're not really seeing the nerve. It's definitely not accessible. There's just kind of a sheet, a plaque that's just covered across the entire thing. So an outside in approach is going to be, quite difficult. So we're kind of only left with that one option, which is to, see what edge we can get outside in. It feels a little harrowing since we're kind of, we're going to be going kind of on the temporal aspect close to the macula, but really trying to see where our planes are and seeing if we can get any sort of separation.
And what about instrumentation wise, right? So you have the cutter. What else have you seen? What else have you done? What do you like?
Yeah, so I've really liked the cutters as much, trying to take the cutter as much as it'll go. And then, obviously there's the option to use scissors. You can use a bimanual technique. We'll get to some at least one technique I hadn't tried previous to this. In this case, you can always think about putting in another port to either put in a chandelier, or if you have an awesome attending who's willing to light pipe for you, you can do that too. And then that just frees up your other hand to be able to, grasp as needed. Maybe you can lift up on the membrane, give yourself a little space so you can either fit your cutter in there or a scissor. Some people like horizontal scissors, some people like vertical scissors. Some people like picks, using picks to kind of sort of get under a plaque and kind of run it down. There's a lighted pick that you can use to try and avoid putting in a chandelier if you like that too.
All right, let's see what you did.
All right, so here we are trying to approach it from outside in. It's giving us a little bit, but as you can see, we kind of hit a dead end pretty quickly. And again, this is kind of the temporal edge of the macula, so we're trying to avoid being too aggressive. So this is when we put in our fourth port, and Dr. Sharma's very kindly going to be sticking in a light pipe to help illuminate, which is such a better view than the chandelier I found. And then now we're going to bimanual. Got a max grip in my left hand to see if maybe it'll allow more separation, better identification of where my cutter should go so that I can be safe. It helps a little bit, and we're kind of finding a bit more of a pocket to kind of get into, but it's still pretty tethered down. Then I'm moving along to another area more superiorly, trying to use a combination of the cutter and then later the cutter with a little bit of max grips as well. But kind of same thing where if we eventually run into the area where the retina is really tented anteriorly, and that's kind of where we are stuck. Here dealing with a little bit of blood, clearing it out. So actually, this is the technique that I was mentioning. This is the visco dissector. I think the Hubbard visco dissector that Dr. Sharma introduced me to. And it's
why don't you pause it? We'll pause it for a second.
Yep,
Let's talk it through. So how do you so this is made by Synergetics Bausch. How do you prep it? What do you put in it? What tell me how you work through it.
Right. So basically the part that goes in the eye, it's a retracting sort of metal tip that retracts a certain amount, and then it's going to be tubed up directly to our viscoelastic that Dr. Sharma is holding and kind of pushing. I believe there's also a way you can hook it up to the machine to push visco for you through foot pedal control, but I'm actually not sure how you get enough visco to like run through enough of that tubing.
Yeah, you can do it either through the micro injector like the Med 1, or you just need like a little bit more viscoelastic. So if you have about a 1 ml viscoelastic, you can put it in a viscous fluid injector. So I like using with the viscous fluid injector. That's what I use. And I use like the foot pedal control. But Sharma likes ultimate control. He's more precise than your foot. So that's a reasonable way to go.
Yeah, if only we all had a Dr. Sharma.
And what kind of viscoelastic do you use?
So I believe we're using a dispersive viscoelastic, although I'm wondering if either would work. I don't know. What do you have any specific thoughts on that, Dr. Sharma?
No, I think either can work. We just use Helon because it's a larger volume when we get the way we get it. So I like Helon for that reason.
I like Helon the best out of all of them. I think Helon, at least in the, Baker taught me how to do this technique years and years and years ago, and I've played with many different viscoelastics. I think Helon works the best.
Okay.
But you could use any. You can use any, but I think Helon works the best.
I've always used Helon because that's how I was taught to use it.
Eric, what
Hey,
was
Eric.
Simith telling you as to where to angle it? Like, what were you avoiding? Were you trying to make space? Can you talk us through it? Because many haven't used this before.
Definitely, yeah. So obviously this only works if you have an entry point, but the good thing is, once you have a tiny little entry point that may not be large enough for you to feel comfortable with your cutter or maybe even, your scissors, this is kind of a duller sort of tip. So you feel okay doing almost a partial blunt dissection as you find your pocket and sort of advance it forward. I'm trying to stay as kind of anterior in the Z plane as much as possible while not, exerting, continued traction on the retina, but, trying to stay as anterior as possible so that I'm sort of in that plane between the plaque and the retina. Once we have a plane, I think we used, I may have kind of skipped over just for sake of time, but once we found a plane superiorly, we kind of took that blood out, gave us a better view, and we thought that, hey, maybe this is a good spot to go. But honestly, we also had a decent spot inferiorly, and I think we'll attack that portion as well. But we're just kind of going into whatever pocket presented itself to us as we attack this thing.
Hey, Eric, I just have a quick question. Is this a right eye or a left eye? I just can't tell because the anatomy is so off.
This is the left eye.
This is the left eye. Okay.
Yeah.
So if this is the left eye, where do you think the nerve is? Do you think you're doing most of your work nasal to the nerve here?
If this is the left eye, I'm trying to think why I'm mixed up
Point to the nerve.
This looks super, it looks like you're supronasal, and the nerve, yeah, is where your little finger is there, right?
Nerve is right there, but for some reason I was
Because you
thinking
kept
this
saying
was
macula, and I was confused why you're talking
Yeah.
about macula. It seems like you're
Because if
not-
that's the case, you are going to be doing a foveal macular dissection right about now. That's my concern. That's why I was asking about
Yes.
orientation, where you're
Yeah, I was
going in.
getting
That's
very
Yeah.
confused too.
Sorry,
And that was my other
we could all
concern
be
too.
thrown off
displayed.
by the plaque here. And the infusion we switched out. So yes, this is going to be temporal side. This is nasal.
Okay.
And this
Because
is
the fovea is like that weak spot, right? So if you're like blindly injecting, I'd worry that you would make a macular hole. But this looks
Right.
safer. That's nasal.
right. I think we were still, I mean, if this was kind of the best place to enter, we may have considered it, but yes, I mean, the way this is angled, I wouldn't point it straight at the fovea if possible. But we're kind of taking what this plaque gives us. All right, moving along here. So as we find a space, we're kind of blunt dissecting a bit, and then you can see where now Dr. Sharma is pushing that viscote, and it might be hard to see, but it's actually doing a decent job of creating or of extending this pocket out further inferiorly and giving us a lot more space so that now we can fit our cutter in and continue our work.
That's nice. That's a good job. I think the nice thing about the viscodissector is you can just adjust the angle as you're working your way through. So you could actually put in a lot more and just follow the injector as you create that pocket. And you could bring it all the way to, the other side, if you will. You just got to be careful and stay in the same plane, but it works really nicely. You can get a lot of this work done very quickly.
Mm-hmm. Yeah, and it also kind of presents additional spaces that we didn't really know existed beforehand. So we'll kind of see the viscote leave the plaque in a certain area, and that tells us, oh, there's a little space there. Now using the vertical scissors to try and dissect off some of the more adherent stuff here.
No, I'm dead.
And at this point, we're using a combination of the scissors as well as the cutter, and then we'll go back to the visco dissector as we get more space and kind of march along. Here we're superior to the nerve. So there is another move there, and
that's beautiful
over the macula there, but again, that's kind of creating that pocket and kind of chomping along. And you can see how that visco just nicely dissected all the way, even more infrotemporally there. So as we release a lot
This
of this
real
stuff,
time, Eric.
right, of course. I'm sure everyone wants to sit through a real-time video of a TRD, right? So, as we kind of get through this, the most adherent portion of the plaque and kind of the most concerning in terms of the status of the retina, if you look, seems to be this inferonasal stuff right here. You can see the retina is just really drawn up. And this plaque was kind of our most adherent. We were going after it. We're kind of thinking, let's not be too aggressive. But obviously trying to take off as much as we can. It didn't look too good at first, but slowly but surely it kind of came off using a combination.
Did you think you need to take it, Eric? Because I mean, you got the AP traction off. Did you? I mean, obviously I know you're about to do it, but could you have left it?
Yeah, I think that we had discussed that, and we're specifically trying to avoid being too aggressive. So this was more just, if it's going to come, let's take, but with the idea that, hey, if it's looking hairy, we'll stop. We at this point released the AP traction. We've gotten a decent amount of the plaque off. Let's not do any hero surgery.
Because of the two bands, I really wanted to segment across it at least once so that it didn't pull up later. But I agree, you could potentially have left it.
Yeah, and then this is kind of a foreshadow, but you'll see even with this plaque gone, the configuration of the retina underneath is a little interesting.
You are pulling everything out of the equipment cabinet here today. This is great.
He knew this was his senior skit.
Of course.
So you can see, underneath the retina still, really contracted. But thankfully the plaque's coming off somewhat. Now,
you just showed I was going to say, you just showed really good bimanual control. You really had to put upward force on that, even that small segmented area, to be able to see the peg and to cut through it. I mean, it's so valuable in these highly contracted diabetics to be able to release that traction. It's really good.
Yeah, I think kind of finding the balance between pulling up too much and pulling up just enough to find a space kind of takes some time. I wish I could say that this entire case went perfectly without a single break, but wanted to show this step here near the end where we're feeling quite good actually, but as we now approach the superior part, there's a little bit of clotted heme that's kind of stuck down, and as we're dissecting under it, kind of taking out the hemes, there's two breaks that we're seeing right under it superiorly. So while I'd love to say that was there beforehand, I don't I think it was the aggressive pulling that might have done it. And then
Can you talk about what you're doing here with the soft tip?
Yeah. So here,
it's actually not a soft tip, it's a back flush, right?
Right. So actually with the back flush, the advantage of it is you can reflux. So we're using a combination of aspiration and also reflux just by, pushing on that little hole covering to kind of blow away the heme. We're trying to get good visualization of the posterior pole, make sure that, we're not missing any breaks, missing any pathology that needs to be addressed, seeing, how the retina looks underneath. But, anytime blood kind of sits on the retina, especially in a diabetic case, pretty quickly it turns into an adherent membrane. So, sometimes you have to aspirate that out or even peel it up. And now we're lasering 360 as much as we can wherever it's flat. And, there's that residual area, especially infranasally, that's elevated. Kind of at this point, Dr. Sharma and I had a discussion, like, do we try to ILM peel over that? What do we do? Do we address it in any way? But the thinking was, this is infranasal. At this point, we've done a lot for this eye, and let's live to fight another day. Let's see how this patient looks. And if there is a need to go back and do, for example, a membrane peel or relaxing, sort of surgery, then we can do that at a later time. But it was decided that, hey, at this point, we're going to watch this and see how it does.
I think smart, very smart. Just playing it with multiple surgeries is fine, and not doing too much, and did so much. You accomplished
I mean,
so
we don't know
much
the
in this
visual
one.
potential is the other thing, right?
Yeah.
So that's
Right, like after all this, is hand motion brief before, is it still hand motion after?
Right. And this was
Carolyn,
the eye that was
Calmation. Come
kind
on.
of
I
chronic
have a
visual
question
decline.
for Dr. Pan. How often are you then peeling ILM on the macula after these complex TRDs? You see a lot of them.
Not super common. It's mostly because I don't know what the visual potential is on these, and I feel like less is more on a case like that. When they're like baby TRDs, then yes, I'll
Yeah.
have them peel the ILM just so kind of really make sure we never have to come back into this eye ever again. But a case like this, you've already done so much. I think doing the ILM, you are gonna make more problems. And if this eye after this is like count fingers or 2400 and you had put oil in, maybe when you take the oil out, you can consider it depending on what the OCT looks like. But I think doing what they did is perfect. I would not do more.
Yeah, I like your the baby TRDs would be ones where it's looking really good. Now you want it to look really good, and I think ILM coming off of that, and but otherwise, Eric has done a great job.
And Dr. Pan, that was a very perfect segue, because here we're, going to go to air, but the question is what sort of tamponade to do. And, we thought about oil versus gas. Again, the right eye is, newly free of any silicone oil, doing better than they had before. So she's using that eye. We had actually decided to do gas because we wanted to, number one, avoid a second surgery if possible, but also more see what the status of this, inferior infranasal retina is going to be without tamponade. So we elected for gas.
Yeah, Eric, you did a beautiful job in this case, by the way. I think when you're young and you're trainees, you're obviously just focusing so intently on the task at hand and the eye. And I think I saw Sunil talking about this in the chat. It's so imperative in these cases, just pay attention to the vascular status of these patients, their blood pressure, their perfusion throughout the case. These are super, super sick eyes. That was one of the key things my late mentor, Joe McGuire, always emphasizes. Even these cases when they bleed and you pop them up to 60 for prolonged periods of time, you may be losing whatever's left, during those moments of a case. Obviously, these are poor prognosis eyes to begin with, but just being mindful of the overall vascular status of the patient is critical. Very nice case.
Yeah, it's
Yeah,
really
I think
good.
I can't stress that enough, Vasan, with you. I agree completely. I think, we constantly talk about, if they're bleeding, jack the pressure up to stop the bleeding. But I try to keep it as low as possible in these cases, as for as long as possible, and really minimize jacking the pressure up to control the bleeding. So I think the pre-op Avastin, pre-op PRP, if you can get it in, we had no view in this side to get pre-op PRP. But that's why I did the Avastin 7 days before.
Nice job. Great work.
Fantastic.
Thanks.
Take us through so we're gonna have to move on here in a second, bro.
Yep. So Here, let's move to the end. So actually, post-op month 3, patient actually as early as post-op week 2, I believe, patient was actually seeing 2250, and it slowly improved to 2150. At one point, actually became their better seeing eye. So we were kind of thrilled with this outcome, and we did not have to go back in, address the infranasal stuff, at least not yet. She is coming back in 2 days actually for her post-op month 6. But so far so good. Sorry, her Optos isn't the best just because of her
The
filter
light's
rate.
bothering her. That's why. That's a good sign. Congratulations, Eric, on 2 years of COBRA, buddy.
Appreciate it. Yeah, just want to say thank you to Dr. Sharma and the COBRA family. It's been real. It's been an awesome time. We'll miss you guys.
That was refractive retinal surgery there. Well done. Our third fellow presenting today is Jared Sokol. Jared is one of our fellows here at Stanford and is moving on to the mountains of Colorado, where he'll be joining the faculty as a clinician educator at the University of Colorado. And he has a COBRA senior special case for us.
All right, thanks so much, guys. In theme to my move, we have extreme retinoschisis here, featuring Charles DeBoer as well. COBRA alum. All right, so this is a 24-year-old male. He was referred to us for an asymptomatic retinal detachment in his left eye. We're the 5th retinal specialist to see the patient, and other people in his family have had vision problems. So here's his right eye. On first glance, it's kind of hard to see what's going on here. There's some like peripheral cystoid changes, and maybe the macula has a weird reflex or reflection, but the retina looks attached in this eye, and overall looks okay on brief view. Here's the left eye. So in this eye, we see these peripheral kind of tractional membranes, all these different pockets of different layers of the retina. The macula looks okay, but there's definitely a lot of splitting of the retina peripherally here. So here's his OCT. So the right eye up top, we see this really significant retinoschisis, and on the on phos red free or infrared, we can see some pinwheeling in the macula there. Left eye, there's a small ERM, not as significant of the schisis changes. As we look peripherally, in the right eye, we have these impressive schisis changes with these different membranes and within different layers of the retina. The left eye, we have some peripheral schisis, but we also have these pockets of subretinal fluid under the retina there. So our plan was to observe. He was asymptomatic in his left eye, and his right eye was also seeing well. We referred him for genetic testing, and we recommended close follow-up. So, our initial diagnosis was probably some type of a hereditary retinoschisis, X-linked retinoschisis, or something on that spectrum. But unfortunately,
Hey, Jared,
yes.
how easily are you able to do that? Like, how accessible is that for if this walked in any of our clinics to get that testing?
So when we do it, we actually have to refer them to our children's geneticist, and then I think she goes ahead and orders the testing. But I believe the retinoschisis is on most of the retinal degeneration panels. Again, we do have to kind of plug them into our geneticist though to get them in that path.
So for us plebs,
Yes.
we can't do that easily. It's a little bit tougher path.
How is it at Cole?
We have genetic counselors. I think that's something that we could do. That's something we can do. We have to just reach out to our genetic counselors and talk it over. But all of this is subject to what exactly you're looking for. If you know what you're looking for, right? So we usually engage our IRD team and you show them the photos, and we get very specific. And then it comes down to insurance coverage, right? Depending on what you're looking for.
Definitely. And there's not a lot that looks like this, so we were pretty convinced on some type of hereditary retinoschisis. So 2 months later, he walks in, still 20/20. This was a OCT done by Lucy Guo on the weekend. And we have some subretinal fluid there encroaching onto the fovea. So now our hand is tied. I think with these retinoschisis cases, we like the myopic macular holes. We only do them when we have to, and we had to now. So the initial surgery was a primary buckle, 4270, with Dr. Guo and Charles DeBoer. And it's a young patient, 24, so we're going to try to solve this problem with a buckle. So here's a quick video of that initial primary scleral buckle. 42 band, a nice wide band, 4 millimeters across, and you'll see we will put it about 4 back here. So Lucy's
Carolyn, Dr. Pan, is this the element of your choice in this type of case?
No, I think I probably would have, if I was just going for an encircling band, I would have done the 40/50. Like it's a little bit wider and like thinner, and then imbricate 7 millimeters. If I'm thinking it's just temporal and I'm still like imbricate elsewhere, but I want to have a broader imbrication temporally, I would maybe do an element like a 276 to support, whatever pathology a little bit more posteriorly. I feel like the 42, I only really use it for combined buccal vits to support the vitreous base. And at that point, then I just use the 41. For me, I think the 42 is kind of like not bulky enough or big enough to truly buckle, but then it's like too fat if I'm going to do a combo.
And I think it's a point, like, as fellows, we model what our attendings show us, and I think you have a favorite buckle, and I think your point's well taken. A 42 is a good one for a buckle vit. But I think, in these primary cases, sometimes you do need to either consider, you're going to imbricate that 42, or you're going to really imbricate it in, or use a wider element. Sunil, what would you go after? Oh, you said 40/50. Oh, look at you.
Yeah, no, I mean, but I think again, I think that the key here is like, at least at some level, did you see a full thickness? This is where the exam I think is so challenging, right? You have to like look and think about where the pathology is. So I don't know there's one right buckle or one wrong buckle. This comes down to where the pathology is, how posterior, how long the eye is. There's multiple elements here. I wouldn't say one versus the other. I would say just the eye will tell you which one you need. So
I think with schisis, it's so hard because,
yes.
is it like the inner hole, the outer hole, where those are located on? Sometimes you don't know. There's multiple, it's like,
and in that scenario, the broader buckle makes sense, right? The 40/50 makes a lot of sense in that scenario. But if you saw it on a careful exam and you saw, oh, there's this solitary break and I see the full thickness, maybe you could do something smaller. But I agree, 40/50 in general for me.
Awesome. Yeah, I think we saw a small temporal break initially, but again, with this schisis, it's so hard to tell. Is it a full thickness, inner outer hole? So, you'll see here we're applying the cryo under a chandelier buckle to a few different areas that we thought we saw full thickness breaks. You definitely see a small full thickness hole down there. And then we marked the break, the most posterior break, which was temporal, which is the one we thought was the main culprit. And then suturing, so we're well behind the marked break. So the break is well supported by the buckle there. Yeah, I think the 40/50 band with like a 7 mil imbrication would have probably gotten us definitely more posterior. And maybe, well, we'll see where the case takes us, but maybe would have changed the future a little bit. So
Dr.
there's our
Kat, would you have drained at this point, or just supported in cryo?
I think that's a good question. In general, for this amount of fluid in like a regular rhegmatogenous RD, I think I would have drained. But here, I think it's a little challenging because you don't feel super confident where the breaks are, and I'd be worried about sort of draining if I was really truly where there's subretinal fluid. So you might consider just sort of watching without sort of draining, but I can see how you'd kind of go in both where you could go either way for this case.
Yeah, it's almost like, what are you draining? There's different pockets. It's just so hard to tell exactly what's what.
Yeah, I mean, there's a reason why sort of any schisis related RD has such a low success rate. You know, it's much lower than our normal rhegmatogenous ones, and much less than in someone like this who we suspect has, you know, an inherited like genetic problem that puts them at risk for this.
Definitely. So here's our post-op week 1. I believe that our most posterior break with some early cryo is right around there. But, you know, we also see there maybe is some subretinal bands. It's hard to tell what layer, but we just observed here and we let the RP pump do its thing. And the retina began to reattach. At week 5, he was pinholing to 20/40. So we were definitely making progress. You can really see on the thickness mapping the fluid going away. But then, unfortunately, at month 2, he has an acute worsening of vision to 21/25. Still amazing he's 21/25 with this detachment. But, you know, we have our fovea off here, and there's definitely something else under the under the retina. And we think it's probably one of these subretinal bands that we saw on the peripheral imaging. We actually, so here is our Optos photo, and we can see there's a little hole that has opened up next to that subretinal band. On the previous Optos, it was not there. So there's just teeny little hole, and our imager's got a really amazing and beautiful shot of the hyaloid at the anterior edge of this hole, and you can see the subretinal band right around underneath it. So this was what we thought was the culprit for our new worsening of our detachment here.
So knowing what you know now, would you have done anything different on that first case? Like, would you have been like, oh yeah, we should have done a buckle vit, or would you have still gone with the buckle to start?
I think I would have gone for a buckle. You know, it's a good point that maybe an element or a 40/50 could have gotten this area. I'm not totally sure what a subretinal band being compressed by a buckle with the hyaloid, if it would have changed things. I mean, it probably would have caused this hole to be on the buckle instead of off the buckle. So maybe just a larger band or a tire element in this quadrant could have prevented this. So now our hands are really tied. We have the buckle on it. I guess we could have done a buckle revision and tried to slide a tire under or a sponge in that quadrant. But, you know, given what we saw on these OCTs, we decided to go in the eye. So our plan was vitrectomy, membrane peel, laser, oil. So here we go. Phakic guy, young, nice clear lens. Temporal retina there, temporal macula is detached. I'm just trying to get a lay of the land here. You know, in a young patient, quickly we're going to get some Kenalog in just to see the status of the hyaloid. Thankfully, the hyaloid was a little more forgiving than I've experienced in younger patients. We are able to slowly lift it, and in these cases, like a lot of pediatric cases, the hyaloid lifting is, you know, maybe the whole or the majority of the difficult part of the case. So we were able to work some of the hyaloid up here. You see it's kind of like this tight kind of napkin ring of hyaloid that we're just using our vitrector. You know, we could use some other techniques here, flex loop, but we were making progress, slow progress, but we were making progress. And luckily the retina.
I'm going to stop you there. Asan, any other techniques? Are you putting perfluorocarbon down? Are you restaining? How do you walk yourself through these like challenging hyaloids?
All the things you mentioned are good. Having that third hand with the perfluorine, especially in like very thin mobile retina like this, is going to be useful. Utilization of stains and dyes. Obviously, you don't want to like do too much or your view's getting messy, but knowing that these eyes typically have hyaloid and then sheets and vitreoschisis, you're just going to be continually peeling all this. And even before I get to this point, I think somebody had mentioned it before. One of our mentors from fellowship in these types of cases, they wouldn't hesitate to just put the buckle on, drain if you can, and potentially even come back later, like planning this as a stage operation. Because sometimes what happens is, by way of, I don't know if it's the convection changes or whatever the buckle does, you may actually successfully induce a PVD over the ensuing month or so. So it could be something that you guys consider. But, you know, These are
And then the other classic question is, how far out do you peel? And I know you're going to say at least to the buckle, but that's not always easy in these young patients. So, like, what will you take as like good enough?
And along those lines, even this hyaloid, like we see these patients with broad posterior vitreous space insertions all the time that are unanticipated. They just deal with in a vitrectomy. It's not like you're going to go in on a pucker patient and put a buckle down, right? So it's an art. I think you feel when there's increasing tension, your hyaloid's not coming as easily, and I will stop, but the fellows be like, you can see this is a very broad posterior base insertion. Not to push your luck. You can keep pulling. You're just going to start ripping everything open at that point. So I'd say it's somewhat of an art. I think we all would agree.
Jared.
Yeah.
So you showed 2 OCTs. You showed one with the macula detached and like subretinal stuff. And then so I see like white stuff in the macula, right? And then you showed the other one that with the hole in the subretinal band.
Exactly.
So what do we think that white stuff under the macula is? Do we think that's just another subretinal band?
That's what I thought probably was another subretinal band. Yeah. Any other thoughts?
It wasn't there before in the first surgery. I don't remember like in
No, I don't believe it was. I do not believe it was there before there in the other surgery. Yeah. So I mean, maybe
you'll know soon, right? I'm anticipating you're gonna put some perfluorine down. I think you're gonna see really quickly what that is, right?
Let me play the video.
Okay.
So we found our kind of culprit hole there. And we're just kind of continuing to trim hyaloid, lift hyaloid. It's quite adherent. You can actually see the subretinal band right under there, that nice kind of thick white-gray rope. And just taking our time to not rip the retina. I feel like, some younger retinas, it can take a lot of countertraction and force, which is nice. Now we got a nice jet of Schlering from the hole, and then our subretinal band kind of just presents itself to us. So, we weren't sure if we were going to go after them, but it was right there in the hole, and we think because the OCT, the hole probably had was created some component from the subretinal band, so we go after it. And I'm just using a mass grip forcep here. Subretinal bands are notorious to snapping and retracting and basically losing it. I was kind of gently teasing this guy out, and I could have kind of wrapped it around my light pipe, which probably would have been a good idea, but it kept coming as one piece, and I just kind of let it take us where it wanted to go. And as you can see, it all snaked out of there nicely.
Nice job. Really satisfying.
Yeah.
Carolyn, any other pro tips? This was pretty pro right here, but any other pro tips?
Yeah, I think what Jared mentioned, he was lucky that this guy, it seemed like kind of like a fibrotic subretinal band and not like the bungee cord ones we normally see where they bounce back once you lose it. But yeah, like the spaghetti technique, using your light pipe as a fulcrum, all of those things are the tips that we tell our fellows when we're going after the subretinal bands.
Yeah, and now the retina, you can see, way more mobile. It's kind of billowing up and almost billowing into my cutter, so we put down some PFO there. And you'll see the macula actually flattens beautifully. So maybe it was some subretinal band, or hard to know, but macula looked pretty flat, so we weren't going to go after anything in the macula at this point. So we were just cleaning up around the break, getting any residual traction off, doing some more hyaloid work. The question is how far do we go? I think trying to get it to the buccal was great. You can see that kind of ring of hyaloid, and we weren't going to get this to the aura, that was for sure. But getting it past all of our breaks and well supported on the buccal was our goal here. And just taking our time. We just depressed, you see these schisis pockets, but we didn't see any other culprit breaks or anything else we wanted to treat. Even more Kenalog, because we were so afraid of vitreous schisis here. And just kind of trimming everything using our PFO marble there to give us some counter traction now that we've loosened up the retina by getting that band out. And then we're going to go ahead and drain here.
Hey, Sumit, I've got two questions for you. Do you think this retina is relaxed enough, or would you be thinking retinectomy at this point? And then when you go to laser, are you just going after the area of pathology, or are you lasering 360 on the buccal or 180 on the buccal?
So I think the retina is pretty mobile right now, and I think you can sometimes be fooled though. And so when you go to air and you go to actually dry, or when you're in or PFO, however you're kind of trying to flatten the retina out, that's when you really get a better sense for it. But if it flattens nicely with the PFO like it did here, then I'm comfortable with just being done at this point. We always like to take the hyaloid out as far as possible, but getting it as far as you can sometimes is all you can do. And some of these eyes with the buccal, if you can get it up to even close to that, they'll do really well. And again, going back to the same principles before, less is more in some of these cases. So I'm definitely lasering the break. And if I don't really see much other pathology, I don't think I'm going to do much other laser. I think I'm just going to do the break here.
Take us home, Jared.
So we decided to do oil in this case. With the retinoschisis, we wanted a long-term tamponade in this eye. The case went really well. We just had this one culprit break. So maybe you could argue we could have gone gas here. But it was also nice to kind of be able to see the retina well in the postoperative period as well.
Do you guys feel like with these potentially, and this may just relate, like high myope or staphylomatous eyes, that you get as good of a tamponade with like surface tension and stuff with oil versus gas? I'm throwing it out there for everyone. People debate this all the time. Jared, what do you think?
I mean, it's a good point. Gas C3F8 is kind of the highest surface tension of the tamponade agents that we classically use. And it kind of does beg the question, is having him face down with C3F8 maybe the best option here? I do feel that silicone oil just does give us a longer term, tamponade, and possibly in this eye who's going to have a lifelong of likely retinal problems, having the longer term tamponade, I think, is probably the most helpful in our in keeping him attached. Yeah, I mean, I'm curious what others would do.
I think it's a totally justifiable decision. There's no right or wrong. I think when you're younger in your career, you almost look at longer tamponade as a security blanket for yourself. And, in these situations, you feel like that retina looks scary if someone put oil in. And I think the longer you do these things, we know like silicone oil toxicity is a real thing. I mean, we see it over the time in our careers, and you just never know who it's going to happen to. And I think the few times I've seen that happen, you sometimes wonder, I just wish I put gas in. But I think this patient's going to do fine either way. And I was just, Sunil, what would you have done?
Yeah, I mean, I agree with you. I think I wrote in the chat I would do gas, but no one's going to fault you. I mean, I think this is yeah, what a win. Good job, great job with the case. I think you gas would have been fine.
Got it. Yeah, and you can actually see this little thing under the retina, so probably a little subretinal band there in the temporal macula. And it actually did kind of melt away. We gave him 5 methotrexate injections just because the subretinal band and risk of PVR here. We discussed this a bit in one of our internal surgical rounds, and we thought that maybe the subretinal band retracted over time rather than melted from the methotrexate. But it did go away, which was great. And this was him at month 2.5, eating away at that oil, starting to emulsify it. He's young, so we're going to take it out probably at 3 months minimum, but soon, hopefully, we can get this oil out and cross our fingers that he'll do well.
Nice job, Jared. Great
Super
work.
job, Jared. Nicely done.
And just a big thank you to the COBRA family, my co-fellows, and Dr. Mruthyunjaya for all his support over the last 2 years. It's been a good run, and I've had a wonderful time here at Stanford.
Jared, did you know about per capita, there's the most macular schisis in Denver, Colorado out there. You're going to be the pro at this.
Oh gosh.
Everybody send them to Jared now.
Okay.
That's a good idea. And he'll definitely use oil in the mountains, so you'll be all right.
Exactly.
All right. Last but never least, Rachel Downs. Rachel is our other graduating second year, and not going too far, staying around, hanging out with us after taking off exactly 62 days of work before starting her next gig here. Excited for you, Rachel. Take us home.
Thank you. Sorry. I'm sorry to be the boomer in the group. I don't have AI art and I'm trying to figure out how to share my screen.
On the bottom of the Zoom, there should be a click a
Oh,
share.
yeah, the big green button. Yeah, that makes sense.
Sorry, you'll get it eventually. It's fine.
All right, give me just a second.
Thankfully, as an attending, you don't have to share your screen very much at these conferences. You just get to sit back and relax.
Someone else can share. Are you guys seeing it?
Yep. Yeah, go for it.
Okay, so this is a case that I did with Dr. Sastry, who couldn't be here today because of happy reasons. His family's growing. So this was type 1 diabetic, 31-year-old man who came to Dr. Sastry's clinic, referred by another doctor who felt that this eye was inoperable. So essentially it was like a classic story. He had really nice PRP in the other eye, which looked great, and had been lost to follow-up from this other doctor for a long time and came back looking like this. Vision was 2500, lots of heme, and the retina looked to be detached, which is confirmed on this OCT. The patient, after that photo was taken, received 2 additional Avastin and had some in the past as well. So there's a fovea off there. And so he's phakic. We decided to do this not as a phacovid, just as a straight vid. So getting into the eye, and we're seeing that some of the membranes have matured a bit since that photo was taken. The highlight was up over the macula, so we started by kind of dividing there and seeing where we could take it. So addressing some AP traction here. And I'm not going to bore you with all of that, but once we got as much of the AP traction off as we could, we started getting to work on some of these membranes. First, the yellow lens on some of the more peripheral areas that we felt were amenable to segmentation, and then put in plenty of Kenalog and decided we were going to go by manual. So starting with a max grip forcep and a curved horizontal scissors, we are working on this membrane in the inferior arcade, trying to keep like the sweet spot, kind of right amount of tension on that retina. And
Hey, Rachel, can you pause for a second? Can you walk us through like when you're doing bimanual, like now that you're 2 years again in it, some tips you've learned on how to do this well. I always talk about it's like trying to pat your head and rub your belly at the same time. So how do you do this successfully?
I've thought of it like, especially first of all, when you pull out these instruments in a case, you're probably gonna, at least in my experience, it's gonna be a longer case, and like you feel yourself getting so much more comfortable as time goes on. So like trust that will happen. And then another thing, I think it's really easy to get so focused on your scissor hand, but don't forget about your forcep hand if you're using the forcep and scissor technique, because that's, I think, where you actually could run into a lot of danger of putting too much traction on these things. So I feel like when in doubt, I just let go of it. You can always go back and grab it again. If you think you're putting too much traction, your hand can drift, especially when you're getting the sense of things. So if you feel that forcep hand is drifting, just let go.
Excellent.
Thank you.
Wise tips. Those are great.
Thanks. So the other thing that I think is nice about bimanual technique is don't forget you can go back and forth between your instruments. So in this scenario, we noticed that we had opened up this sort of valley that was very amenable to using the cutter. We also wanted to use the cutter to keep our sort of flap a little bit shorter. It was getting kind of long. So coming in here and kind of segmenting that and cleaning that up a bit. And then in the spirit of full disclosure, I do think this was a nice case, but I did make a mistake with my bimanual, which you'll see here, some bleeding. So I definitely nicked the retina there. It's a really fine balance of putting enough tension that you can see your planes, but not so much that you're actually bringing some retina into your scissor mouth. So that's an important lesson. So then once I realized that there is a break, we're trying to be very meticulous about clearing the hyaloid, of course, off of that break and going in and marking it and then doing some more dissection there.
And these are the Alcon curved horizontals. Is that what you're using? And so back in the day, so the scissors that we had available to us were much sharper. This has like one kind of almost like the edge is broken off on one blade of the scissor, and that actually gives you a little bit more like kind of blunter dissection. It's not like as snippy sharp, so you can kind of be up against when it's closed up against the tissue, with a little bit of cushion because it's just not as sharp. Back before, it would be like you'd be poking
Interesting.
holes.
Yeah.
So it would cut better than these do. I feel like these don't cut. You have to kind of keep snipping. Unless you have like really good traction and you just get right at the peg. But it also it means that the other ones would, you'd be cutting more easily, but also through the retina too.
Yeah, pros and cons. So now working on one of these superior membranes, kind of same technique, so max grips and curved horizontals.
You're going like outside in, it looks like.
Yeah, at this point we're going outside in. I kind of feel like I just, in these TRD cases, try to just take what I'm being given and not be too like prescriptive about how I want to go about it. So going back to the cutter here, thinking that I had more space and then realizing that I didn't think that move was safe. So I'm going to switch back in a second. Now scissors in my left hand, forceps in my right, and addressing the rest of this plaque.
Lefty scissors. Are you kidding me? Come on. Nice job.
Someone told me you have to use both hands if you want to be a retina surgeon.
That person who told you wasn't very good with their other hand, so that's fine. Sumit got better as time went on. So how much, you're pretty nasal here. Do you really think you have to go after that? Why was your reasoning here?
Yeah. I think that was such a broad membrane when we were starting that it seemed insane not to go after it. And then watching this back today, I was like, oh, I probably could have stopped sooner than I did. But I think there was like never a question that we were going to at least address that unit.
There's such a point when you're doing these cases and it's rolling and you're on the right track. You're like, I can peel anything and I can trim anything. I'm going after it all. Again, hubris though. Remember, I will just always tell you guys, just make sure the retina will remind you very quickly that it is always in charge.
Words to live by. So then going in and just doing some peeling. This is sped up. I was moving very slowly and paying like close attention. Are there points where I'm putting too much traction? And I felt that there was one, this like white area here. So then kind of peeling up to it and using the scissors to segment and then delaminate that area. Oh, and then this time I just decided that I wanted to bring the light pipe back in to act as counter traction because I felt like it would be more gentle of a tool to help me do this move. And then peeling up.
That was a nice move, Rachel. That was great.
Thanks.
I haven't seen this video. It looks good. You're doing great. Well, awesome.
Thank you. I'm getting some more of that hyaloid up and then moving to some of our temporal traction, but we're starting to feel happy. And believe it or not, I cut out, I mean, I'm sure you guys do believe it because you've all done cases like this, but I felt like I was cutting out the majority of it, even though it feels like now I'm showing a lot of that trimming. More Kenalog in the eye. I'm a big fan of Kenalog. And then just trying to see how far we can safely extend that hyaloid out using one of our breaks to drain and filling the eye with air. And then we're going to go with laser. So lasering up any breaks or any areas that we thought looked at all suspicious. And then of course, adding PRP, doing a little bit more drainage at the breaks and the nerve. We're going to close a couple of our ports, and then we opted for C3F8 as our tamponade in this case. So doing our gas exchange here. And 2040, I couldn't believe this. I was so happy. So really looked beautiful, quite the change from before, and like the stunning OCT. Obviously, a lot of this is luck that he wasn't too ischemic, as many of the patients who present to us like this are, but he's doing great. He's very happy. So thanks everybody.
What a what a case to end on! Holy cow! Well done. You know
I'm
that's
tearing up a little bit watching these
that's
four.
just
Like
gorgeous.
it's
Like
just
these are amazing cases, everyone. That's the four of you have shown, you know, incredible growth. I'll speak to the two that are graduating here. What an absolute pleasure to train. I know Rachel and Eric. I know all the faculty here are so proud of them. So this is great. Good for you guys.
Thank you. Thanks so